Good evening to everyone. As Sister Sheba told, I am a Sajan.V. Since 8 years, I am working in Parliament as a nurse. So, in my experience, and first of all, I joined in Parliament in first time after just completion of my nursing career. I newly knew about subcutaneous infusion or subcutaneous bolus giving of injection and continuous infusion by subcutaneously. How it possible? I thought it's impossible. But since 8 years, I'm experiencing, and now also I can say subcutaneous infusion is the best route for giving infusion or giving injection. If one patient is needed, means we can give by subcutaneously. So today we are going to discuss about the subcutaneous infusion. It's an important topic basically in palliative care. So first of all, I am just simply dividing the layers of skin into just three: dermis layer, subcutaneous layer, and a muscle layer. We're going to discuss about the second most layer, subcutaneous layer. So subcutaneous layer or subcutaneous infusion have another term also. Can anybody tell? If you know means, can anybody tell another term for subcutaneous infusion? You can put your answer in chat box also. Okay. Subcutaneous infusion is another term is hypodermoglysis. Hypodermoglysis, if you seeing the term, only the term hypodermoglysis means also we will get the meaning from the term itself. Just divide the term into three: hypo first part, dermo second part, and glysis is third part. Then hypo means below the dermis layer, the subcutaneous layer. Glysis means administration. So the definition of hypodermoglysis or the subcutaneous infusion, which we can say as like, it's an administration of small volume of medicines like injections and the type of bolus to the subcutaneous space, or large volume of like infusions. Maybe if we needed to, if we seeing on patient with the dehydrated cases, if we planning to rehydrate means also, we can rehydrate as like infusion by subcutaneously. That is the hypodermoglysis or the subcutaneous infusion. So mainly the subcutaneous infusion, continuous infusion, we can give in cases as like mild to moderate dehydrated patient. If we seeing on patient means we can rehydrate by subcutaneously. If it from moderate to severe means we can give by subcutaneously because the tissue absorption which will be very poor in the moderate to severe and severe dehydrated cases. So mild to moderate dehydrated cases, for the planning for any rehydration means we can give by subcutaneously. Then if one patient already taking any oral medication, now the patient condition is very bad or patient is unable to swallow the medication or food due to the dysphagia or swallowing difficulty, then we needed to switch from the oral form of medicines to injections. Then we can give the injections by subcutaneously. Then for the same, I am repeating, for the rehydration purpose, if we planning to give 3 liter or 6 pint of fluid, if you planning to give for a patient within 24 hours, means we can give by subcutaneously up to 3 liter per day or within 24 hours. Then already I told in palliative care, the subcutaneous route is very, very important. So how it's important in palliative care? Some of the patient or majority of the patient, if he's seeing with nausea or vomiting. Nausea or vomiting means uncontrollable vomiting. Maybe the vomiters contain the fecal matter. Mainly the gastrointestinal related cancer condition means also due to the partial or complete bowel obstruction, that time patient will affect with the severe vomiting. Maybe it's having the fecal matter also. In such situation, the oral form of medicines needed to continue for the symptomatic management, or maybe the patient needed to take the food or fluid by orally means it's totally impossible in that situation of vomiting and nausea. Such situation, we needed to give some injections or we needed to give some infusions for the maintenance of the quality of patient as a part of the symptom management. So we can give the injection by subcutaneously. Then already the any oral lesion or esophageal any lesion or any oral ulcers in mouth and throat region also, patient will refuse to take the medicine and food by orally. Then we can give by subcutaneously the injection and the infusion. Then already I told gastrointestinal system in CA, at any time we can expect the intestinal obstruction, partial or complete. That time we can continue the same oral form of medicines for the symptomatic management for the patient. Then we needed to depend the injection by subcutaneously we can give. Then unconscious patient, I'm not telling about the unconscious patient. Generally we seeing in the ICU setting. If one patient is end of life stage, now the patient is becoming condition is general condition is deteriorating. Now the patient is totally unconscious stage. Then for the maintenance of the quality of patient, we needed to continue or we needed to give some fluid for the patient means we can give that infusions or symptom management medicines we can give by subcutaneously for the management of the symptom. Then, if one patient with the severe pain means according to the pain scale, we can, example, we can say as 9/10 or 10/10, that much severe pain, already the patient is affecting. Patient is crying with that much pain. Such situation, already maybe the patient is getting any oral medicines. That painful situation, again the oral medicine as a SOS basis or maybe another form of any oral pain medicines we suggesting in that situation means is totally inappropriate due to the painful situation. Such situation we can manage by injection form of medicine, then only we can move to the tab form of medication. So that type of intractable symptoms, according to the situation, we may needed to give some injection for the symptomatic management. Such situation, by subcutaneously, we can give the injection form of medication. Then, as if one patient is getting oral form of medication, suddenly the patient is unable to take the oral medication, maybe due to the vomiting or any swallowing difficulty. If they needed to continue the same dose of tab form medicine by rectally also we can suggest for continuation. In some situation, the rectal route also inappropriate. Example, if the patient is having CA rectum, we can give by rectally. Or maybe the patient is affecting with already having the loose stool or any hemorrhage. Or maybe in that such situation, we can give or we can suggest the rectal route for continuation of the medication. Such situation also for the symptomatic management, we needed to give injection by subcutaneously we can give. Then we moving to the sites. Which are all the common sites we can give the subcutaneous injection? Can anybody? Common sites for subcutaneous injection. At least some sites already you maybe some sites you already practice in your setting.
Around the umbilicus.
Okay. Any other?
Thigh also we can give over the thigh also, as well as the deltoid muscle also you can give thigh subcutaneous, as we give insulin and all.
Okay. Any other?
The outer aspect of thigh.
Okay. Okay, thank you for your responses.
Gluteal area.
Okay. Okay, these are all the common sites. Some sites already you already answer. First one, upper chest region or intercostal plane means this region, upper chest or intercostal plane, or then upper arm. or outer aspect of upper arm. So the measurement we can say as like 7.5 centimeter downward from the shoulder region and 7.5 centimeter upward from the elbow joint. The outer aspect or lateral aspect of our both hand we can give. Then abdomen around the umbilicus 2 inches away from the belly button. Abdomen around the umbilicus we can give. Then outer thigh or lateral aspect of thigh region, both thighs we can give. Then scapular region also we can give this subcutaneous injection. But commonly in our palliative care setting also, we mainly practicing upper arm and the lower arm. Why? Because in our palliative care, not only the care in the hospital, the caregiver also needed to know how to give and where to give. Then the caregiver only can continue this injection if it needed for the patient in their home setting also they can continue. So as a part of the caregiver education, it's easy to understand for the caregiver in both upper arm and the outer thigh. So these region commonly we practicing. If it's contraindicated in some situations means only we selecting other areas. In first one, if suppose we choosing the upper chest or intercostal plane for the female patient means be very careful. Don't involve in the breast tissues because it will damage the breast tissues. The absorption will be very poor. So the site will be the upper chest region only. That thing we need to keep in mind. Then some sites we cannot give the subcutaneous injections. First one, lymphedema. Mainly the example we can say CA breast means affected site, the lymphedema we can see in the upper arm. So already the lymphedema is there means we can't give the injection subcutaneously on that same arm because it's a no absorption will be there. Then if the site we going to choose that area already having any irradiated skin already or any scar, any tumor means we can't give on that area because it will affect the tumor or it will disturb the site. Then near to bony prominence or on the bony prominence we cannot give the subcutaneous injection. Then any inflammation or any infection sign is there means also we cannot give, we need to skip the area. Then if we suppose we going to give the injection or infusion in the abdomen means also already if the patient having any ascites or the extremities having or any pitting edema means also we cannot give because already the fluid collection is there. Then again we giving means also it will not absorb and it will not help for the symptomatic management. So these are all the common sites we can give and we cannot give. Then these are all the some of the examples of the medication most commonly we practicing in our palliative care setting. So studies are going on, some daily some more medicines are proving to give by subcutaneously, but these are all the common medicines. For an example, I'm telling injection morphine, injection haloperidol, midazolam, metoclopramide, hyoscine butyl bromide, injection fentanyl. These are all the common medications we can give. Then these are all the medications or these are the examples for the medications we cannot give. Stemetil, injection stemetil, diazepam, chlorpromazine, antibiotics, then hypertonic solutions. If maybe already I told for the rehydration purpose, we can give the infusion by subcutaneously. But in our setting also we practicing 0.45% to 0.9% normal saline. Only the normal saline we practicing by subcutaneously. In some countries, they are practicing dextrose normal saline also by subcutaneously, but we not at all practice, only the normal saline we practicing. Then hypertonic solutions as like more than the concentration, like 0.9 to more than from 0.9% we cannot give, as like 3% NS or any antibiotics, antifungal or any other infusions we cannot give by subcutaneously because the tissue damage will happen, the absorption will be very, very poor. Then we moving to the procedure. As like every procedure, we need to explain the procedure to the patient and the family. Why? Because mainly the palliative care, first of all, if they are coming in palliative care, the subcutaneous route of giving injection, it's a totally new one for them, because they already saw like
catheterization.
Intravenous route of administration or intramuscular route of administration, everything they already have they are aware about that because already they see. But subcutaneously, this much infusion or this much frequent medication by injection form of medication we giving, it's totally new one for them. So we need to explain about the procedure to the patient, why we need to give or any other complications, everything we need to talk with them. Because in subcutaneously, if we giving on bolus injection or infusion means also that site on mild edema is normal only. At every time on mild edema will happen. It's a period after some time it will subside. So we need to explain to them. Otherwise, they will compare the edema happening in the subcutaneously with the intravenously. So we need to explain. Then first step is like wash hand washing is very important. Then we set everything, assemble any fluid, fixed fluid and the tubings, prime line, anything we need to set. Then after the selected site, if we choosing the left lateral aspect of the upper arm means we need to select the site. Then we need to clean the area as like swab soaked with antiseptic solution. Then circular motion, circular manner, already selected site from the center to outward. Center means the tip we need to prick. That's from the center to outward. Circular manner we need to clean and leave it to few seconds for drying. In between the period of drying, again we don't touch with our fingers on that cleaned area. Then mainly we using the scalp vein set or SV set, butterfly cannula only we using for putting in the subcutaneous space. So insert the needle. While inserting time, the bevel means tip of the needle on us like a cross section on look is there. So that bevel region will be in upward position only by inserting time. 30 to 45 degree angle we need to prick, and after inserting the needle we need to secure the wings of the butterfly cannula or SV set along with the tubing by using any adhesive tape or occlusive dressing. Then after that, whenever we starting the infusion means we need to adjust the drip rate as per the prescription of the doctor. Then we can move to the video. In video, you can see about the procedure. Doctor has advised
Subcutaneous infusion of fluids or hypodermoclysis. Mr. Mahesh has advanced cancer of pancreas.
Good morning, Mahesh. Doctor has advised to give on subcutaneous fluid.
Requirements for the procedure: a tray containing one sterile tray with lid, sterile cotton swabs, intravenous solution, normal saline 500 ml 1 bottle, 1 IV set, 1 number 23 SV set, 1 pair clean gloves, antiseptic solution, adhesive tape, 1 small Macintosh, 1 kidney tray. Check IV solution. Check the infusion container for sediments, turbidity, change in color and expiry date. Wash hands with soap and water and wear clean gloves. Remove the outer packing of the IV solution. Remove the protective cap at the entry point. Remove the outer cover from the IV set and remove the protective cover from the entry point. Spike the solution container with the IV set without touching the entry point.
After starting injection or after starting the infusion for a patient by subcutaneously. First of all, if we giving one bolus of injection for a patient by subcutaneously means we need to maintain the rate as like 1 ml per minute. That's the maximum, 1 ml per minute. So if we needed to give more than 1 ml as like bolus of injection means maybe it's 3 ml or 5 ml something we needed to give means we need to take that much time. So that much patience we need to have for giving this bolus of injection in this subcutaneously. Then any infusion as like drip we starting means 20 drops is the maximum. So 1 ml or the 20 drops is the rate or volume we need to maintain by subcutaneously. If the rate or volume is increasing means it will cause the feeling of pain for the patient on the site and the fluid overload also. Then already in starting slides, I already told if we planning to give 3 liter or 6 pint of fluid, we planning to give by subcutaneously means maximum within 24 hours we can give. In here, that for that explanation I am telling, in one site, for a one site, 1.5 liter or 3 pint within 24 hours maximum we can give. Like that, one more site we choosing means again 1.5 liter we can give. So within 24 hours in 2 sites, maximum 3 liter or 6 pint of fluid we can give within 24 hours. Third site, it's not possible. Maximum 2 sites, 3 liter, it's a maximum we can give by subcutaneously within 24 hours. So this one is a theoretically we telling, but practically, mainly in palliative care, there is a no needed to give this much of fluid for a patient. If any infusion as like drug we planning to give means also our main aim is to maintain the quality of the patient only. So these much of fluids, it's a practically it maybe it's not needed for the patient. So as like every procedure, after the procedure something we need to do and we need to keep in mind while doing. After the procedure, after selected site, after prick, everything we set and we started the infusion also. After starting the infusion, after delivering, within 2 hours, don't cross 1 liter. That we need to keep in mind. Then after starting, we need to document about the infusion, the name and the rate or otherwise volume we need to chart in the medication chart. Then check the patient after 1 hour of starting the infusion or after 1 hour giving the bolus injection, we need to check the site. There is any edema. Mild edema is normal only. Already I told we need to explain to the patient and caregiver. But the edema is increasing or the edema is not at all subsiding for after some time or any fluid leakage on the edematous area means also we need to assess about that. Then if any necessary, the absorption is very poor. If we notice means also we can give some mild gentle massage we can give for subsiding the edema. But after that also again the edema is increasing or not at all absorbing means we need to change the site. Then in this already I told in palliative care as a injection form or as a infusion form we mainly choosing the subcutaneous because it's have so advantages mainly in palliative care. That's why only we choosing the subcutaneous. Why? Because first one is the low cost. We need to consider the patient and the family, their financial condition also. Because I think you already know if on IV cannula means how much its cost will be. Maybe it will starting from 100 to 120, 150 like that. According to the brand value, it's the cost is changing. But here, this SV set, the cost is only 18 rupees, 18 to 25 rupees only the SV set. This SV set only we using for giving subcutaneous injection and the infusion. So first advantage is the low cost only. Then more comfortable than the IV administration for the patient and the staff also. Then in IV, if we giving the infusion, continuous infusion as like drip, means also maybe some complications we can expect as like pulmonary edema, or the poor fluid absorption means also it will cause the fluid overload, mainly happening in the IV administration, but it not at all happening in the subcutaneously. Because why? Because in IV administration directly the thing we pushing to the intravenously means it will directly involving in the circulatory system. But here in subcutaneously, there is no involvement directly to the circulatory system as like IV. Here, what is happening means the medicine be pushing to the subcutaneous space. It's totally storing in the subcutaneous space. From the space, it will absorbing. Gradually, it will absorbing. So there is no connection with directly or no involvement directly with the circulatory system. So the complications which may will happen in the IV, it not at all happen in the subcutaneously. Then simple insertion, it not at all distressing as like IV for the patient. Here you can imagine for the IV cannulation, what are all the painful steps we continue, and at last we will succeed the one successful IV cannulation. Maybe after some time or after 1 or 2 days, the cannula is not at all pattern, or its patterns is lost means also same painful process we need to repeat, and we will succeed for the IV cannulation. That painful process is continuing in the IV cannulation procedure. But here there is no painful procedure as like IV cannulation, because already I told we not at all need any IV for the subcu insertion. Selected cleaned space, we need to prick, maintain the degree of angle while pricking and inserting the needle 30 to 45. That's only. After the pricking and after keeping, one thing also in IV cannulation, suppose today morning we put on IV, we given on bolus injection. Maybe after maybe today next dose or next bolus dose of injection we needed to give it maybe at night or next day morning. Maybe in between the clot formation in the IV, it will block the cannula. Maybe we needed to change. But here already I told no involvement in the circulatory system. So that's why here no clot formation also. At any time we can give and reinsertion and injection also. It's possible in the subcutaneous site. So here mainly already I told not only the hospital setting, in home setting also we can educate the caregiver, or otherwise on home care team also, if we going for seeing one patient in the home setting, if we planning to give an injection means also by subcutaneously it's easily we can give. Why? Because home care team maybe one nurse will be there in the team. No, maybe if that staff is not much experience in the IV cannulation means also there is no supervision by the seniors will not get for that staff for putting on IV. But here in this subcu, if we practice in home care setting means also there is no supervision is needed. Without any support, with a single person, that staff, that nurse can put the subcu and give the bolus injection or infusion by subcutaneous in the home care setting also. Then other complications as like thrombophlebitis, maybe it happening in the IV, not at all happening in the subcutaneous. Same reason only, it's no involvement with the circulatory system. Then as like same only septicemia or systemic infection as like a complication happening in the IV, it not at all it will happen in the subcutaneously. Then at any time we can stop and start the injection by subcutaneously. Because already I told there is no clot formation in the subcutaneously, but in IV there is some clot formation and it will block the IV. So next restarting of injection or restarting of infusion after a few hours or after 1 day in IV, it's maybe not at all possible. But here in subcutaneously, after hours or after days, at any time we can restart and we can stop the injection and the infusion by subcutaneously. Then as like everything, as like advantages, some minute disadvantages also will be there in the subcutaneously. First one, possibility for the irritation or any inflammation at the infusion site or injection site. But one important thing is there is no involvement in the circulatory system. So this inflammation or any infection it's happening means also it will affect only the site. It will not cross and it will cause the systemic. As like a systemic infection, it will not go. In the same that site only maybe the irritation or inflammation, if it happen means also will be there. Then possibility of the leakage. Maybe in some patient, the subcutaneous space will have the poor fluid absorption. Means the leakage of fluid or medicine on that subcutaneous site. Maybe it's possibility for happening. Then some patient very rarely it will cause the allergic reaction. Like allergic reaction, how it happening means for fixing the SV set on the selected pricked area by using some occlusal dressing or any adhesive tape only we using for fixing. Maybe some patient that adhesive tape material is allergic for some patient. May it will cause the allergic reaction. It's very rare only, maybe will happen. So these are all the minimal disadvantages happening in the subcutaneously. Then some side effects and the complication, how it will can rectify. We're going to explain. First one, localize the edema. Already I told before starting the procedure, we need to explain to the patient and the family as like mild edema is normal only on that side. After some time, it will subside. Maybe it not at all subsiding or edema is increasing means we can give mild massage on that area. Gently mild massage we can give on that area and we can try it for subsiding the edema. Again, same situation is repeating. The edema is increasing means we can expect the poor fluid absorption on the selected subcutaneous space. Then we need to change the site. Then inflammation or infection or any cellulitis. Some disadvantage point I already told. This inflammation cellulitis, how it happening means already during the procedure steps already I told. After cleaning, don't touch again with our fingers on the already selected cleaned space. If we practicing poor aseptic technique for the procedure means it will cause the inflammation and the cellulitis. So during the procedure, we need to keep in mind the step will be very aseptic technique only. Then pain and discomfort on the insertion site. Already I told as a rate and volume 1 ml per minute or 20 drops per minute, that rate and volume we need to maintain. Maybe the rate or volume is increasing means it will cause the pain for the patient on the pricked site or infusion site. So we need to check the rate and the volume. If it maybe it's increased rate or volume means we need to reduce the rate and the volume for the injection or the infusion. It will subside the pain. Then puncturing of the blood vessel. There is no chance for puncturing of blood vessel while insertion during the insertion time. It's very rare only. Maybe it's happening means how it happening means after pricking or after fixing the subcu spaced needle, even the keeping the needle and even keeping the infusion or injection with along with that only, patient can move and the patient can do every activity with the subcu needle. So in between, while moving time or while doing any jobs, any wall corner side or any door side, maybe it's hitting and inside any capillaries or minute blood vessel is puncturing by the insert already kept needle in that space, it will cause the rare chances, but may will cause the puncturing of that minute blood vessel and it will leads to the presence of blood tinged fluid inside the tubing, external tubing of the SV set. So if we are seeing like that any blood presence or blood tinged fluid presence inside the connected tubing with the SV set means we need to change the site. We cannot continue the same site for giving injection or the infusion. We need to change and we need to select another site. Then hematoma around or redness around the insertion site. If the patient already getting any anticoagulant medication, or if the patient is already having the condition as like low platelet count level, then this hematoma around the insertion site, it will happen. So we need to check the history also. Then infusion device occlusion. It's very rare only, but we can expect, because for giving maybe if we planning to give some medication for hours for continuous infusion means also we can use syringe infusion pump or infusion syringe driver. That type of machines, it will maybe in between have some alarms. So we need to check the tubing, external tubing, any kinkling, any it's happening means also the device occlusion will happen. So we need to check the tube and we need to correct it and we can resolve. So these are all the side effects and complications may happen, that management also we explained. Then as a nurse or as a medical practitioner, some responsibility is there after starting the infusion by subcutaneously. After giving the injection and after giving the infusion, after 1 hour, we need to do the first assessment. Then every 4th hourly, we need to repeat the assessment on that area. First one, the area have any tenderness or any hardness on the area, that subcutaneous area have any tenderness or any hardness, or there any presence of any hematoma or any redness there or not, we need to check. Then insertion site, there is any leakage of fluid. Already I told mild edema is normal only, but along with the edema, the fluid is leaking out through the space means we can expect it's a poor fluid absorption. We can continue on that same area. We need to change the site. So we need to check any leakage is there or not, any local tissue irritation. If the patient is telling any pain or any irritation on that area is there or not, any redness or any presence of blood and or blood tinged fluid in the tubing, external tubing of the SV set, or any displacement of the cannula, means displacement of the SV set from the secured space. It's happening means if we seeing the displaced cannula means we don't encourage to or we don't reinsert the same cannula. We need to change and we need to put on another one. So these are all the things we need to check on a subcutaneous space or subcutaneous tissue every 4th hourly. So already I told for giving continuous infusion by any medication means mainly we using syringe driver or syringe, mainly we using syringe pump or infusion pump. But in our setting, we mainly practicing syringe driver. It's just I am introducing only. Syringe driver is a small device only, looks like this only. The syringe driver is a not at all working with power by using battery only. The syringe driver is running. It's a very simple device only. Along with the syringe driver, the patient can mobilize and patient can do every activity, whatever all they can do along with the syringe driver. So this syringe driver, mainly 2 types are there: per hour setting syringe driver and per 24-hour setting syringe driver also. In our setting, why we using the syringe driver more? Because in our setting, our main thing is our management is no, our palliative care management can restrict the patient or patient family activity due to these machines or due to this management. So along with the management or these type of machines also, if the patient is capable means or if the patient is able means, they can mobilize and they can continue their activity, at least daily living activities means they need to continue by self along with this type of management. That's why only we promoting these type of syringe driver in our setting. They can carry the syringe driver even in bathroom or even in taking bath or even their traveling time also they can carry this type of syringe drivers. So along with this introducing this machine also, I'm just completing my session.
Thank you, Sajan, for the wonderful session. Anybody has any doubts on this, please ask. Anybody? So how many of you are practicing subcutaneous infusion in your sessions?
Ma'am, I have one query.
Yes, ma'am.
As we give this subcutaneous IV fluid, so but there will be edema over it or what like that? Because if anything goes out and it forms edema, it is very painful. But the subcutaneous injections means like,
Sajan, do you want to respond?
So, thank you, madam. Already I told we need to maintain the rate and volume. If we giving on infusion means we need to set maximum rate 20 drops per minute. That's the maximum within 1 minute. So that rate and that volume we need to maintain. Then mild edema is normal only because already I told there is no involvement in the circulatory system. First of all, whichever the medication or whichever the infusion we inject into the subcutaneous space, it will go there and it will collect there for few time. Then only gradually it will absorbing by the tissue and it will moving to the system. So mild edema is every time it's normal only. So this edema is increasing, or if the edema is not at all subsiding, or the edematous area, that area is leaking out by the medicine or fluid, means we can expect the poor tissue absorption on that subcutaneous space. Then we cannot continue on that area. We need to select another site.
okay, thank you, sir.
Thank you, Sajan. So as Sajan said, slight edema is normal, but you can just imagine and the subcutaneous tissues, we can try to give infusion or injections to that space. Initially, little pain is there, but once the absorption starts, the pain will subside.
Okay,
So
okay.
that you have to talk educate with the caregivers and the patient. But this is a new method for them. So if you go with the subcutaneous infusion, definitely you have to tell the patient and caregivers this. So then only they will get an idea. Otherwise, in between also they will come and report you. So edema is there, edema is there. So just tell them before that.
Okay, thank you.
Yeah, usually we will tell them in intravenous infusion. If there is any edema, please report us. That kind of things we usually tell them. They will be, they might be thinking like that. So that's why. Okay, any other questions? So unfortunately, we don't have a case presentation today. If you have any questions regarding this, please ask us. We will try to answer it. So I would like to know, anybody practicing subcutaneous infusions in your settings? Nobody is in this group. Okay. Okay, thank you. So Reena is asking, is it painful? So initially, little pain is expected, but when the absorption start, the pain will subside. Another question is, Java is asking whether we have to maintain temperature of fluids. No. Same fluids you can give. No, you can give all medication, most of the palliative care medications you can give, as Sajan said earlier, but you can safely give intravenous infusion, that normal saline is the safest intravenous that infusion with which you can given through subcutaneously. But the DNS and ringer lactate also can be given, but usually we used to give normal saline. Sajan, do you want to add anything?
No, ma'am.
No questions? I hope this subcutaneous infusion session is clear to everyone. No questions. So if it is clear, we can wind up the session. So before that, I would like to highlight two things. As Sajan said, this is one of the safest method for giving fluids or injections because there is no medical practitioner is needed. If there is a trained volunteer there, they can also give this infusion through intravenously. We need to train them. And also we have to keep it in mind, most of the medications which we are using in palliative care can be given through subcutaneously, because morphine, haloperidol, midazolam, Buscopan, these all medications which we can give through subcutaneously. And a few disadvantages are also there, that also you have to keep it in mind. But you have to think about the advantages and make the patient comfortable as much as we can, because most of the time when the patient is coming to the palliative care department, that veins are not visible. At that time, multiple needle tricks will be given to the patients. Usually we will try a lot, because our intention is to giving intravenous fluids. So one thing, if there is a severe dehydration there, you have to this is not a good method for rehydrating the patient, because if there is a mild dehydration there, this is enough. The subcutaneous infusion, because the absorption is very low, the diffusion method only. What is diffusion? So the diffusion is higher concentration to the lower concentration to the higher concentration. So you can instead that given to the fluid and the subcutaneous space, and then gradually the absorption will be there. So through the method is diffusion. So here the absorption is very slowly. That time, in case of severe dehydration, this is not a good idea for rehydrating the patient. So our other points, Sajan has discussed very well, because and also we have to think about the rates and absorption, because more than on normal at a time we can't give. And also if you want to give multiple, that more than 1.5 liter in a day, you can choose two sites. So one site you can give 1.5 liter per 24 hours. So up to 3 liters you can give on through intravenous subcutaneously. So these all things you have to keep it in mind. Always you have to teach the patient and caregivers about before starting subcutaneous infusion. Okay.
Sister, one more.
Ma'am, whether we can give the 25% dextrose?
No, ma'am. We can't give 25% dextrose, because this will cause cellulitis. So you can safely give normal saline, and also you can give the dextrose normal saline, DNS or ringer lactate. But the safest solution is normal saline.
Okay, thank you, ma'am.
Sajan, can you wind up?
Yes, ma'am.
Okay, thank you, Sajan, for the excellent session. We don't have a case presentation today. We can wind up today's session. Thank you all for joining today's session and clarifying your doubts. Thank you.
Thank you, Mr. Sajan, for the very interactive section. Thank you, Sister Shiba, for facilitating and clearing the doubts. Thank you, everyone. Kindly fill the feedback forms given below. Thank you.